everyone. Thank you, Swapnil sir, Preetham sir, Hema ma'am, and AIOS for organizing this webinar and giving me an opportunity to be here. So I'll be presenting a simple case of a masquerade. Otherwise, I would have labeled as a proptosis masquerade, but the endemic allows me to say it as mucormycosis masquerade. So this is a 55-year-old male presented with the left eye proptosis with loss of vision. Right eye was 6.6 and the other eye finger counting 2 meta. Sorry, the vision is reversed here. History of COVID a month before, and he is a known case of diabetes and hypertension since 10 years. So when we see the right eye, something like this, it's proptosis, lid edema, and a semi-dilated pupil. And the fundus is showing central retinal vein occlusion, a typical appearance of the hemorrhages all over. Now, since patient came with the proptosis and got admitted in the medicine with the deranged blood sugar, he had a presumed diagnosis of patient is suffering from mucormycosis, and patient was started on amphotericin B already. By the time we realize that we need to do imaging and go ahead, we understand that the since it's a COVID going on and there is a endemic of mucormycosis, all the cases coming with the proptosis are considered as ROCM unless proven otherwise. So this was the imaging of the patient. Now look very clearly. What I noticed here is compared to the right and left eye, the muscles of the right eye are very bulky compared to the left eye, and otherwise sinuses look pretty clear, not much of involvement there. But patient had already started on amphotericin B, and then ENT wanted to intervene. So they repeated a COVID test. On the third day of admission, COVID test came positive, and patient had to be shifted to the COVID hospital. And the treatment change and the diagnosis change. Now it became mucormycosis with COVID treatment with amphotericin plus steroid plus antibiotic to tackle the pneumonia patient was having. Now, this treatment was going on, and let's consider that the treatment was blessing in the disguise to the patient, because by the time the patient came back post-COVID, on day 11, the proptosis is resolved, and you can see something here, which is very promising, a dilated episcleral vessels all over the conjunctiva. So then again, I was of the opinion that this is not the usual mucormycosis case. And ENT did their nasal endoscopy and sent a swab for the KOH. My diagnosis was again, it was more of a vascular pathology. So I insisted they did MRI imaging with contrast, angiovenography, everything reported by radiologists. It came inconclusive. But since the eye was persistent, they went ahead with doing a digital subtraction angiography. And this is image sent to me by a radiologist. I'm not very good to explain you that, but it was a very low flow caroticocavernous fistula, indirect one, which was about to close, but still had a lot of vascularity and some flow there. They did a minor DSA intervention to close this fistula, and patient is doing well. I don't have a post-op picture to show because this happened just last week. So I just want to say that every proptosis is not a mucor. You need to, as an operating surgeon, see every image yourself, and better to keep an open mind for differential diagnosis and possibly, especially in the typical presentation of the any case. Thank you, sir.
Thank you.
Very nice case, Sumeet.
Thank you, sir.
Sumeet is the incoming secretary of BOA, and he is the man behind the recently concluded Grand BOA festival.
So that is not true.
Sir, your comments are Preetham sir and Hema ma'am. And Vikram, if you want to add something.
Sorry. I think we were discussing about COVID-related pathologies, and this is a classic example, where we have to keep our eyes and ears open, because there is so much of COVID around us that and it can mimic so many things as pathological, and the etiology could be totally different. I think this was an excellent case, Sumeet.
Sumeet, the episcleral dilated vessels, were the hallmark to this disease. And I'm quite surprised that in spite of being a low flow fistula, you still got a little proptosis, because I had a similar case where a low flow carotid cavernous fistula presented only with a red eye and mild lateral rectus palsy, but there wasn't any proptosis. So yes, low flow indirect cavernous carotid fistula must be kept in mind. And the red eye should have, it's good that you caught attention to the red eye, because they were typically corkscrew type of vessels. And there isn't any role of venography. MRI angio would have been fine.
Okay.